Spinal nerves are part of the peripheral nervous system but originate from the spinal cord. Most spinal nerves are mixed, meaning that they carry both sensory efferent fibers and motor efferent fibers. At certain levels of the body, the spinal nerves become fused, forming a complicated pattern of fibers called a nerve plexus. In this section, we will examine the general anatomical features of mixed spinal nerves, examine the important nerves from the plexuses, and define and discuss dermatomes. Peripheral nerves in general are wrapped in connective tissue coverings analogous to skeletal muscle. Each segment of the spinal cord has a pair of spinal nerves. Each entire nerve is surrounded by the epineurium. The epineurium projects into the nervous perineurium, which divides up the nerve into bundles of axons called fascicles. Each axon is surrounded by a thin and delicate endoneurium. There are 31 pairs of spinal nerves. These supply all parts of the body except the head and some areas of the neck, which are innervated by cranial nerves. The naming convention for spinal nerves is straightforward. They are named according to their point of exit from the spinal cord. There are 8 pairs of cervical nerves C1 C8, 12 pairs of thoracic T1 T12, 5 pairs of lumbar L1 L5, 5 pairs of sacral, and 1 pair of coccygeal nerves CO1. Notice that there is one more pair of spinal nerves emanating from the cervical spinal cord than there are vertebrae. This is because the first 7 pairs exit the vertebral canal superior to the vertebrae for which they are named, but C8 exits inferior to the 7th cervical vertebra, between C7 and T1. Inferior to the cervical level, each spinal nerve leaves the vertebral column inferior to the corresponding numbered vertebra. Recall that each spinal nerve connects to the spinal cord through dorsal and ventral roots, with each root forming from a number of rootlets that attach along the length of the particular spinal cord segment. The roots are carrying either sensory dorsal root or motor ventral root fibers. The roots in the cervical region are short, but they get progressively longer inferiorly because we outgrow our spinal cords, ultimately forming the cauda equina. The spinal roots join to form short, only 1 to 2 cm spinal nerves. After emerging from the intervertebral foramina, each spinal nerve divides into a small dorsal ramus and a larger ventral ramus, as well as a tiny meningeal branch. Like the spinal nerve, each ramus is mixed, carrying both sensory and motor fibers. In the thoracic region, the ventral rami of the spinal nerves split off another ramus carrying autonomic nerve fibers. These are called the rami communicantes, and their fibers enter the sympathetic trunk located on both sides of the vertebral column. The sympathetic trunk is comprised of ganglia clusters of sympathetic neuron cell bodies connected to each other, forming a chain. The next 2 slides show in more detail the pathways that the fibers take. For simplicity, we will consider the motor and sensory fiber pathways separately. We will begin by considering motor fibers. The somatic voluntary motor fibers and nuclei innervating skeletal muscles are diagrammed in red. The visceral motor fibers and nuclei are blue. Somatic motor fibers leaving neurons of the ventral horn enter the rootlets, which combine to form ventral roots. After fusing to form the spinal nerve, the motor fibers enter the dorsal or ventral rami. The dorsal ramus of each spinal nerve carries fibers to the posterior trunk, where they innervate a narrow band of skeletal muscle and skin somite in line with its emergence from the spinal cord. The ventral ramus is larger, and with the exception of segments T2 T12, all ventral rami branch and fuse with one another lateral to the vertebral column, forming complicated nerve plexuses. The preganglionic visceral motor fibers enter the white preganglionic ramus of the rami communicantes. From here, they can synapse with a postganglionic neuron at the same level to enter nerves innervating smooth muscle, glands and viscera of the thoracic cavity, or travel in the sympathetic chain to synapse in a ganglion at a different level and enter nerves innervating the abdominopelvic viscera. In any case, the postganglionic fibers seen in black can travel up or down the chain in the gray rami to reach the nerves of either the dorsal ramus innervating smooth muscle and glands of the back, or ventral ramus innervating smooth muscle and glands of the limbs, body wall. The organization of the sensory fibers is a little less complicated. Sensation is divided into somatic and visceral sensations. The somatic sensations emanate from exteroceptors and proprioceptors of the body wall, back or limbs depending on the ramus. These are illustrated in red. Visceral sensation comes from interoceptors from the same regions and from the viscera. These are shown in lavender. Notice that both somatic and visceral neurons have their cell bodies located in the dorsal root ganglion, and they enter the dorsal horn of the spinal cord. The visceral fibers from abdominopelvic organs travel in the rami communicantes to enter the spinal cord at the appropriate level. This slide shows a transverse section through the thorax. Locate the spinal roots, spinal nerve, and dorsal and ventral rami. The thorax is the only region of the body that the ventral rami arrange in a simple segmental pattern. The ventral rami of T1-T12 form the intercostal nerves which travel protected in the costal groove located on the underside of the rib. Intercostal nerves and their branches supply the intercostal muscles lying between the ribs, the muscle and skin of the anterolateral thorax, and most of the abdominal wall. The intercostal nerves are wrapped in CT along with an artery and vein supplying the same body segment. This combination is called a neurovascular bundle. Two thoracic nerves are an exception. The fibers of T1 enter the brachial plexus to be discussed later, and T12 lies inferior to the 12th rib, making it a subcostal under the rib rather than intercostal between the ribs nerve. Spinal nerves T1-T12 have a simple, segmental pattern of distribution. These nerves pass directly out of spinal cord to the periphery and supply structures in a narrow band corresponding to the body somite. These include structures located in the intercostal spaces, axilla, chest, muscles of thorax, deep back and some abdominal muscles. Everywhere else, the ventral rami form nerve plexuses. Nerves emanating from regions of the spinal cord that control the muscles of the neck, upper limbs, and lower limbs combine to form complex nerve plexuses. This is a developmental phenomenon resulting from the fusion of small skeletal muscles into larger muscles of compound origins as the limbs formed. The fibers of ventral rami of adjacent spinal nerves combine forming compound nerve trunks giving rise to four nerve plexuses, the cervical, brachial, lumbar and sacral plexuses. The cervical plexus is formed by the ventral rami of the first four cervical nerves. Most of the branches are superficial cutaneous and supply only the skin around the neck, ear and back of the head and shoulder. These include the lesser occipital, transverse cervical, supraclavicular and great auricular nerves supplying the skin of upper chest, shoulder and neck. The other branches innervate muscles of the anterior neck. The deep motor branches include the ansa cervicalis originating from C1-C3 which innervates the infrahyoid muscles sternothyroid, sternohyoid, omohyoid, the segmental cervical nerve C1-C5 and other branches innervating the deep neck muscles like the geniohyoid and thyrohyoid, as well as the levator scapulae, scalene, sternocleidomastoid, and trapezius muscles. But the most important nerve of all is the phrenic nerve which originates from C3-C5. The phrenic nerve is the only nerve innervating the diaphragm. Clinical notes: irritation of the phrenic nerve causes spasms of the diaphragm or hiccups. If both phrenic nerves are severed, or if there is severe injury to the spinal cord at level C3-C5, the diaphragm is paralyzed. This can be fatal unless the victim is placed on an artificial respirator. The brachial plexus is the most complicated of the four because it innervates the complex musculature found in the upper limb, particularly the forelimb muscles. The brachial plexus is situated partly in the neck and partly in the axilla, and can be palpated just superior to the clavicle at the lateral border of the sternocleidomastoid muscle. It is formed by the intermixing of the ventral rami of C5-T1. The brachial plexus has four main subdivisions. Moving from medial closest to the spinal cord to lateral are the roots, which are the ventral rami of C5-T1 spinal nerves. At the lateral border of the sternocleidomastoid muscle, the roots unite to form three trunks: upper, middle and lower. The trunks are large bundles of axons from several levels. The trunks divide into anterior and posterior divisions. In general, the anterior divisions serve the front of the limb and the fibers from the posterior divisions supply the back part of the limb. The divisions pass deep to the clavicle and enter the axilla where they give rise to three large fiber cords: lateral, medial and posterior. Cords are named based on their relative position to the axillary artery. The brachial plexus ends in the axilla where they give rise to the main nerves of the upper limb. 5 of these nerves are particularly important. The axillary nerve branches off the posterior cord and runs posterior to the surgical neck of the humerus. It innervates the deltoid and teres minor muscles. The musculocutaneous nerve is the end branch of the lateral cord. It courses inferiorly supplying the biceps brachii and brachialis muscles. Distal to the elbow, it provides for cutaneous sensation of the lateral forearm. The median nerve runs through the anterior forearm where it supplies the skin and most of the flexor muscles. On reaching the hand, it innervates 5 intrinsic muscles of the lateral palm. The median nerve activates muscles that pronate the forearm, flex the wrist and fingers and oppose the thumb. The median nerve supplies sensation to the lateral palm, thumb, digits 2, 3 and half of 4 on the anterior surface, and the dorsum of digits 2, 4. The ulnar nerve. They arises from the medial cord and descends toward the elbow where it goes behind the medial epicondyle forming the funny bone, and then follows the ulna. The ulnar nerve supplies the flexor carpi ulnaris and the medial part of the flexor digitorum profundus. In other words, the flexors not supplied by the median nerve. It produces wrist and finger flexion, adduction and abduction of the medial fingers. Its sensory distribution includes the remainder of the skin on the anterior surface of the hand, the medial dorsum and digits V and half of 4. The radial nerve is the largest branch of the brachial plexus and is a continuation of the posterior cord. The radial nerve wraps around the humerus in the radial groove, then runs around the lateral epicondyle of the elbow. It divides into a superficial and deep branches. The motor fibers innervate all the extensors of the upper limb, forearm supination, wrist and finger extension and thumb abduction. It is also sensory to the skin. Overlying the back of the metacarpals and thumb, this slide summarizes of the 5 main nerves to the arm, their origin from the spinal cord and what they innervate. Damage to the brachial plexus can have devastating effects on upper limb function, paresis, paralysis, and loss of sensation. Sports injuries to the plexus can occur when the upper limb is pulled hard and the plexus is stretched as when being yanked by the arm. Swinging children by their arms can result in permanent damage to the plexus with lifelong effects. Falling hard on the top of the shoulder such that the humerus is forced inferiorly can also damage the plexus. Trauma to the radial nerve results in weakness to the forearm extensors because their innervation has been compromised. This leads to the inability to extend the wrist, a condition known as wrist drop. Another common disorder involving the radial nerve is referred to as Saturday night paralysis. Recall that the radial nerve wraps around the humerus in the radial groove. When the arm is slung over the back of a hard bench or chair, the nerve is compressed against the humerus. In addition, the brachial artery may be compressed as well, leading to ischemia, lack of blood supply to the tissue. This is what happens when your arm goes to sleep. When an intoxicated person passes out with their arm slung over the back of a park bench, the compression lasts so long that the entire arm is temporarily paralyzed. The condition, Saturday night paralysis, gets its name because Sunday morning the emergency room would filled with revelers from the night before that woke up with a limp arm having no feeling. This condition can result if crutches are used improperly or are not fitted to the patient correctly. Erb's palsy makes up 60% of the disorders of the brachial plexus. It results because the lower roots C8T1 become stretched. This is caused when the brachial plexus is stretched by a sudden fall, as when one catches themselves, or injury resulting from someone yanking on the arm or pulling it up above the head. It is referred to as waiter's tip because the position of the paralyzed arm and wrist resembles a waiter discreetly receiving a tip in exchange for special treatment. Recall that the ulnar nerve supplies the flexor carpi ulnaris and innervates most of the intrinsic hand muscles where it produces wrist and finger flexion, adduction and abduction of the medial fingers. It is also sensory to the skin of the medial aspect of the hand. When this nerve or its roots in the plexus are damaged severely, individuals have difficulty making a fist and gripping objects. The little and ringer fingers become hyperextended at the knuckles and flexed at the distal interphalangeal joints, resulting in a condition known as claw hand. Hitting the funny bone is a very common, and usually temporary injury. The ulnar nerve passes around the medial epicondyle and is exposed when the forearm is flexed. Hitting this nerve against the epicondyle causes tingling and pain to the medial arm and little finger. Personally, I think it should be called the oblique nerve because it really hurts when it is struck, and it is only funny to the people watching the victim writhe. The in pain. Damage to the median nerve results in difficulty pronating the arm and adducting or abducting the fingers, but the greatest functional impairment is difficulty opposing the thumb and index finger. The median nerve runs down the middle of the forearm and passes under the flexor retinaculum to enter the hand. A form of carpal tunnel syndrome results from repetitive flexion which compresses the median nerve against the flexor retinaculum. This nerve is severed in suicide attempts when the victim tries to slash their wrists. The long thoracic nerve branches off the roots of C5-C7 and travels inferiorly to innervate the serratus anterior muscle. The serratus anterior rotates the scapula so that its inferior angle moves laterally and upward. It is also the prime mover to protract and hold the scapula against the chest wall. When this nerve is chronically compressed, as when doing military presses, or activities such as rock climbing, the scapula wings out away from the thorax. The lumbar plexus arises from roots L1-L4 and actually lies within the psoas major muscle. The proximal branches innervate the anterolateral abdominal wall muscles, genitals, and psoas major. The ilioinguinal nerve L1 provides sensation to scan of the genitals and proximal medial aspect of the thigh, inner thigh. Genitofemoral nerve L1-L2 is sensory to the scrotum in males and labia majora in females. These structures are homologous, meaning that they have the same embryological origin, as we will learn later on, and the motor division innervates the cremaster muscle in males. Stimulation of this nerve causes the cremaster to contract, which elevates the testes cremasteric reflex. This is a means of regulating temperature for sperm production. The obturator is motor to the adductor magnus, gracilis and obturator externus muscles. The femoral nerve L2-L4 is the biggest of the plexus. It is motor to the quadriceps and sartorius muscles of the thigh and to the pectineus and ilia. Cus? Damage to this nerve results in an inability to extend the leg at the knee, quadriceps and sartorius. Observe the course of the nerves of the lumbar plexus in the diagram above. If the spinal roots of the lumbar plexus are compressed, the individual will present with an abnormal gait because the femoral nerve innervates the prime movers of both hip flexion and knee extension. Other symptoms may include pain and lack of sensation of the anterior thigh. You should know the spinal roots ventral rami and the structures served by the nerves pictured in A of the diagram. The sacral plexus arises from spinal roots L4-S4. Notice that the sacral and lumbar plexuses overlap. Because of this relationship, many fibers of the lumbar plexus contribute to the sacral plexus. Consequently, these two plexuses are frequently referred to as the lumbosacral plexus. The sacral plexus supplies the gluteal region, floor of the pelvis and the lower extremities. The largest nerve of the sacral plexus, and for that matter, the largest nerve in the body, is the sciatic nerve. It is formed from spinal roots L4-S3, and supplies the entire lower limb except the anteromedial thigh femoral nerve. The sciatic nerve is actually two nerves, the tibial and common fibular, aka common peroneal, which are wrapped together into a common sheath by connective tissue. After leaving the pelvis via the greater sciatic notch, the sciatic nerve courses deep to the gluteus maximus and enters the posterior thigh medial to the hip joint, from which it gets its name. Sciatic means of the hip. Right above the knee, the two divisions of the sciatic diverge. The tibial nerve supplies the posterior compartment of the lower leg, and the common fibular nerve innervates the knee joint, the fibularis longus and brevis muscles, tibialis anterior, extensor hallucis longus and extensors digitorum longus and brevis. The superior gluteal nerve stemming from roots L4, L5, S1, is motor to the gluteus medius and minimus and to the tensor fasciae latae. The inferior gluteal nerves L5, S2 innervate the gluteus maximus. The pudendal nerve stemming from S2, S4 supply the skin and muscles of the perineum, which is the region that includes the external genitalia and anus. Pudendal, by the way, means shameful, just a historical reflection of the views at the time this nerve was named. Compression of the sciatic nerve can result in a variety of sensory and or motor deficits depending upon what nerve roots are affected. The above diagrams show the sensory distribution of the nerves of the lumbosacral plexus. Simple sensory tests can be conducted to help determine what levels and fibers are compromised. Damage or pinching of the sciatic results in pain extending from the buttocks down the back of the leg. Sciatica is a relatively common condition characterized by intense stabbing pain radiating over the course of the sciatic nerve from gluteal region to toes. Below the knee, injury to common fibular peroneal nerve innervating the tibialis anterior results in a condition known as foot drop. In this case, the patient is unable to dorsiflex the foot while walking, which can cause the individual to stumble and fall. If the tibial nerve is damaged, the calf muscles cannot plantar flex the foot, resulting in a shuffling gait. Other common injuries to the sciatic result: F. Rheum or herniated disc, pressure from the uterus during pregnancy, osteoarthritis of lumbar and sacral vertebrae, and overzealous intramuscular injection in the gluteal region. The area of the scan innervated by a single pair of spinal nerves is called a dermatomy. Every spinal nerve except C1 innervates dermatomes. Knowledge of dermatomes is very useful to the clinician because it is possible to precisely determine which nerves are damaged and therefore, what level of the spinal cord is injured. Damage or infection of a spinal nerve or dorsal root ganglion results in a loss of sensation corresponding to the region of skin supplied by the affected nerve.